Making the leap from analogue to digital dentistry is pretty daunting. After all, the techniques we learned in dental school work pretty well for the moment. But is it good enough for us to just stand still? Don't we owe it to our patients and ourselves to keep up with evolving technologies so that we can offer the very best care now and into the future? Welcome back to Schein TV. I'm Peter Norton. During this event, we're going to get some expert advice on how to get started in digital dentistry so that we and our patients aren't left out of the exciting possibilities that are available only to digital dentists. Dr Anthony Mak works in private practice with particular interest, training and expertise in cosmetic dentistry, implantology and emerging dental materials and technologies. Dr Aodhan Docherty is also a private practitioner with a keen interest in cosmetic dentistry, orthodontics and dental implants. Gentlemen, you both have a wealth of experience in digital technology, so thank you for joining Schein TV.
It's my pleasure, Peter. I'm very happy to be here.
Thank you, Peter. Appreciate it.
As always, we'd love to hear your comments and questions during the event. If you're watching us on the Henry Schein website, you can submit comments and questions on your current screen, but depending on the device you're using, you might need to exit full screen mode first. If you're watching us on Facebook Live, make sure you're watching us from the Henry Schein Facebook page. That's important because we won't see your comments or questions if you submit them on any other Facebook page. Remember to like and share this post so that your colleagues don't miss out either. This event will last about an hour and we'll let you know at the end of the episode how to claim your CPD certificate. Anthony, we hear the term digital dentistry more and more these days, but what actually constitutes digital dentistry?
Oh, look, Peter, I think in dentistry, digital dentistry has been around for a long time. Anything can be considered digital dentistry, from even a digital x-ray is considered digital dentistry. But I mean, I guess tonight we're really focusing on some of the newer tools that are available for us now to actually use and help us in terms of and change the way we do our daily workflow. I mean, tonight we focus on a lot about workflows and apps and scanners, intraoral scanners. I think that's how that has brought the digital dentistry really right up to the day-to-day practice of general practices, I guess. Tonight we're going to talk a little bit about what is digital dentistry. Is it a myth or reality? You know, Aodhan, what do you think?
Well, I think it's been around for a while now. I think that, you know, we're only coming to really start appreciate what digital can do for us now, as you said, with all these apps and different bits and pieces. But different forms of digital dentistry has been available for a long time in laboratory settings and other settings in dentistry too. Yeah,
I mean, for myself in my practice, it's really reality. I mean, every day, I don't think I can live without my scanner now. I don't think I can, you know, when I don't have my scanner, I almost feel a little bit uncomfortable in the practice. Is it the holy grail of dentistry? There's a lot of talk about this, and I think tonight, we would like to share. I mean, in my hands, I don't think digital dentistry or scanning and all this is the holy grail of dentistry. It's just another tool for us to use and improve and help us to do what we do. I mean, the basic dental knowledge is still required, and I think the traditional methods that's worked for so many years are still considered a standard for us. But I really
kind of lets you do what you're already doing, but better.
Yeah, I really think that, you know, it improves it. I think there's still a long way to go. I think in terms of, I think we can always improve on where it goes. And I think, you know, in a few years' time, we'll be talking about completely different things in terms of how it's emerged. But yeah, and I think it's just more of a modern approach to dentistry. That's how I would word it. Aodhan, what do you think?
Yeah, I would agree. I would say, you know, we can't really call anything the holy grail, but it's another tool in our armamentarium where, you know, we can use applications these days. We can use different bits and pieces that digital has to offer us to enhance our patient experience and to really give our patients more.
Yeah. Look, I mean, in terms of when we talk about digital dentistry or focusing on intraoral scanning, I mean, is it just a replacement for the impression? I mean, I think traditionally, that's what the mindset is. Is it, can we just replace the conventional alginate or PVS impressions with an intraoral scanner? But I think, you know, in 2019, I think that this workflow or how to use the digital scanner is much more than that. And I think, you know, yes, I feel that it can replace the impression in a lot of cases. I mean, in my practice, I mean, we're doing probably 90% or 95% of us our work in impressionless, or what we call scanning. I mean, there wouldn't be a case where I wouldn't really try to scan, but I'm probably one of those crazy nutheads that just want to scan every single time. But I mean, Peter, in my sort of practice, I think that it definitely does replace the conventional impression.
Well, can you talk us through some of the specific benefits of digital dentistry then?
Look, yeah, definitely. I mean, look, in terms of just replacing the impression, we have so many tools to us that we can use now. We can use digital dentistry or the scanning and apply to what we call smile design. In the last few years, I mean, smile design's been around for a long time, but it's made it so much easier now to be able to use some of these tools. I mean, we can use it for orthodontics, and then a lot of orthodontists are taking up intraoral scanners because it just makes their life so much easier in terms of bracketing or indirect bond-ups, clear aligners, or even study models. I use a lot for implant planning. I mean, I haven't placed an implant without doing a implant planning or surgical guide with my Implant Studio app. I just find that it's just forms part of my practice now, and it gives me that safety that I know that I'm always in the right position with my implants. But Aodhan, I mean, have you used some of these other tools as well?
So, you know, wear monitoring and patient monitoring is going to be quite a big thing, I think, in the coming future. We're scanning our patients. For me personally, you know, I've been doing digital maybe for about 4 years now, you know, a fraction of what you've been doing it for. But as we're scanning our patients on first visits and then on recalls, now we're getting the ability where we can, you know, monitor and see, are those teeth rotating? Is there relapse going on? Is there ortho issues developing? Or is that wear getting worse? You know, I don't know. Previously, in the old days, I would say, what would you do? Would you be taking alginate impressions every year or two and trying to measure them up and things like that? Or
oh yeah, I mean, patients will love that. Not alone.
Exactly.
The dentist will hate it too. So yeah,
that is just one of the tools. I mean, the ability to be able to monitor the wear is something that's going to be in the future. We're going into an aging population. We're going to deal with a lot more erosive and attritional wear that we traditionally would be only identified, but we wouldn't be able to monitor. So many times we say, let's watch this, but we can really now communicate with the patient by, let's scan this, and then we can see it in a year's time, whether there's changes or not. You know, traditionally we've been very static in what we do. Like, we can only use an articulator, but now we can actually measure how the jaw moves, and we can actually scan that. And in the last few months, I've been using these apps where I can actually scan a dynamic occlusion, and my labs have said, this is great, because it actually helps them in their design, because we can not just look at a static occlusion, we can actually see the dynamic movement of the jaws. I mean, in terms of now, we're getting fluorescence filters where we can look at active bacteria activity, which helps in the aid in terms of diagnosis, in terms of whether the patient there is some caries, potential caries. I mean, I don't think that it replaces the traditional key concepts of diagnosing whether a lesion is carious, but these are just tools, and I think most importantly is communication. It helps with our communication. I think you're going to talk a little bit about that now, aren't you?
Well, that's the thing, Aodhan. I mean, if we focus on the scanners themselves, what are some of the opportunities that having a scanner has opened up for you?
Well, I suppose I'd break it down into a few areas. I'd say with the application of digital scanners, we can use them for the digital impression. We can use it during case presentations and for diagnostic aids, as we were saying, for transillumination or for fluorescence, and for its applications. So, in terms of the traditional approach with a digital scanner, we always think of restorative first, right? So we always think, well, we're talking about crown, we're talking about bridge, we're talking about maybe single implants and things like that. And our digital scanners, have, for me, kind of revolutionized my process, because, for patient ease, how nice is it to get a scan versus an impression? I don't think there's any question about that from a patient's perspective. I think it's a very nice part of treatment that we can offer. For whitening trays, for example, we traditionally will take impressions and things like that, but if we can offer, we've got a scan taken from your last visit, or we've got a scan taken at your hygiene visit here, you were interested in whitening trays, it's not to sell to patients, this is to encourage case acceptance, And it's to offer patients something which maybe the gag is they didn't like, or patients not liking impressions, for example.
Aodhan, you've mentioned, we've had this chat many times, you've talked to me about the successes you've had with conversions or communicating with the patient. I mean, how is that, I mean, would you ever do it without a scanner now? I mean, I don't think, from my point of view, I totally agree with you, but how are you using the scanner and the tools to actually increase your, I guess, communication or case acceptance?
Good question. So for me, when we got the scanner in our new practice, I traditionally was using impressions there. And what I did is I brought the scanner, and it's always in the hygienist room. So when the hygienist walks the patient in, they're saying, "What is this? What is this? Technology? What is this?" And she'll explain, "Well, this is a digital scanner. We can take scans of your mouth. A scan will take a minute and a half, whatever it might be." And that opens the door just to conversation. "Oh God, I hate impressions. Oh, I always gag with impressions." Well, yeah, we can do these sorts of things now. And the patients might discuss, "Well, I always wanted to do some whitening, for example." But I also think it's excellent for orthodontic interventions. We can take our digital scans at certain points now where we can make aligners where we don't have to be starting with a scan and making 20 or 30 stacks of aligners. We can scan and then make up 6 aligners, say. We can then rescan at that 6 mark after they've had that. So we can have really precise treatment. And for digital guides and digital splints, I found that it's very useful and very handy as well.
So basically, there's a lot of applications to it. It's not just the impression replacement. I guess we can use it for so many things. I mean, once you've got this scanner, it's like a world opens, and how time that you can save and what you can do, I guess.
I agree. And the old saying, a picture is worth 1,000 words. Well, I would say when I've got my patients in a consultation and I'm sitting there with their photos up, I also have the scanner. And I think that if a picture's worth 1,000 words, what is a 3-dimensional scan worth? That is just intangible. I'm showing them the wear, I'm showing them the broken fillings. I can show that by pictures. But if I've got a scan, that is just enhancing communication for me. And patients love it, and they're getting to have a better insight into their own mouth and to see what's going on. And I think that's really invaluable. Are you using?
I think patient engagement really is one of the big things that we're all striving for. Thank you for your questions. If you're watching us on the Henry Schein website, you can submit your questions on your current screen, but you might need to exit full screen mode first. And if you're watching us on Facebook Live, make sure you're watching us on the Henry Schein Facebook page, because otherwise we won't see your comments or questions. And remember to like and share this event to your colleagues. Aodhan, can we talk about using a scanner as a diagnostic aid?
Yeah, well, I would say in terms of diagnostic aid, we've spoke about visualizing, so worn areas, broken areas, fractures. But we've got new tips across lots of different scanners where we're being able to use transillumination, we're being able to use fluorescence, and it's opening the door, as Anthony said, to give us better insight into what might be going on in a certain area and to give us peace of mind that we are making the correct diagnosis.
Well, Anthony mentioned certain apps that are associated with digital dentistry. What sort of apps are we talking about?
A couple of the applications might be the patient monitoring, as we spoke about, but also the smile design. So smile design for me is something which has formed a backbone in the cosmetic kind of portion of my treatment. So for new patients, I like to do a smile design if they're interested in discussing any kind of cosmetic improvements of their teeth. And I'll show you a couple of patients here where, in terms of workflow, we're having the consultation, we're doing the smile design, and they can have this sent to their phone. It's something that is so revolutionary, I think, that they can go home with photos on their phone of the smile design. It enhances lab communication because then we can plan with the lab what we're looking for. They can do a digital mock-up, and we can make a putty key and transfer that to the mouth for a temporary.
Aodhan, why don't you briefly tell the audience, what is smile design? I mean, I think it would be really good for them, for those people who haven't used a digital scanner before, haven't used apps before. Show us some of the cases or how you actually do it.
Yeah. So you'll see a case here. This is a young lady who, on presentation, I'm not going to go through all of the history of her dental issues, but she's got anterior worn dentition, and for her, she wanted to she's finally ready to discuss a cosmetic option to lengthen her teeth and to be more confident in her smile. And she's a bit hesitant. She wants to be, confident in going ahead with treatment. So for me, slowing things down is a big thing, and I can use the Smile Design app to demonstrate to her what's possible. We basically draw up outlines of the teeth that we would like to place, and we can show her what that would look like sitting in her face. This is not, this is not the be all and end all of this is what you're going to look like straight away after treatment, but this is to give her a rough idea of what she could look like, what she could improve.
And it's constantly improving. I think, what you just said in the future is probably will be that we can transfer that smile design directly to the final restorations.
Exactly. And this is not, this is, you'll see the before and the after here. This is where we've done planning and we've walked through basically, and this is done in composite resin. So composite resin taken from a putty key, which was made from a template that the lab had made from my smile design. And you'll see another gentleman here who, on presentation, again, anterior wear, generalized issues with his teeth, and we walked him through. He's an older gentleman and he doesn't want to rush into anything either. So we need to give our patients confidence in what we're offering them. And we can see that we walked through doing the same sort of progress to a temporary for 3 to 6 months or so, and then going to the final restoration.
Well, Anthony, what are some of the other benefits of digital dentistry?
Medical records. I think having the scans there, having proof that this is what you did, keeping in a soft copy is one of the keys. Obviously, traditionally with the models, it's impossible to find a model more than a couple of years old. Patient comfort, we never talked about that, but I'm going to show you some evidence that patient actually prefers scanning. With the intraoral scanner, you can actually scan bits and pieces. You can give the patient a break. You can scan one segment, give them a break, and scan another one. I mean, in larger cases, I'm not sure if it's happened to you where you've done some bigger crown and bridge cases where you've spent 15, 20 minutes placing a retraction cord, you take the PVS impression, and then you take it and your heart sinks because there's one little drag.
It's a lot of retraction cord placement
exactly.
again. Yep.
And then you have to do that again. Whereas here, if a digital scan, all you need to do is cut that little area out digitally and just rescan that. And it just makes life so much easier. I mean, look, in a nutshell, and I will probably progress from here now, but in a nutshell, I just compare digital dentistry to phones. I mean, we all have a smartphone. But if I compare it to a traditional phone, which we've accustomed to, maybe the younger generation may not be able to accustomed to, but they can both make telephone calls, right? But if I had to give you a choice now, and where you can pick up a smartphone, where you can take photos, you can WhatsApp, you can go Facebook, would you ever go back to the analog phone?
Not in a hurry. It takes a long time to dial, and it hurts your fingers.
Excellent. Now, are we going to do a bit of smile design, or are we going to show a case that Aodhan's going to show us how smile design works?
I believe that's happening.
Let's
is
do it.
Now a good time for you, Aodhan?
Yeah, I think it is.
Great.
Cool. So we'll see here shortly. This is a patient who I've shown just before with anterior wear, and with this application, we can drag his photograph into the app, and we start by marking some landmarks here. We mark his pupils, we mark the wings of the nose here, and we mark the commissures. And this will reset the photograph, give us his midline. And with this application, essentially what we want to do is mark the inner borders of the lips here. This will give us a frame for which we can then start placing our teeth and doing our smile design. We can do lots of different things with this smile design. We can change the shape of the teeth. See, we go for rectangle teeth. We can change it to square teeth. We can change the proportions. We can increase the heights of the teeth. We can reduce certain areas. And what this does is give us an idea of where we want to place the teeth within the patient's face. So this is all facially driven. We can use the different little buttons above to mirror certain teeth if we've set one side and we want to mirror it on the other, or if we want to separate and do certain teeth separately. We look here, and this is where we can change different shades. So for me, for older patients, I always like to match the shade of their current dentition with what we're working on, essentially. I don't want to brighten this up too much. We don't want to go bleach white for this lovely guy. We want to maybe make it a little bit similar to the lower teeth here. We can look at different highlights, so we can take the specular reflections and things like that off the teeth, and we can add the shadow of the lip or reduce it. And you'll see in here, some people will ask, well, what about the old teeth? I can see this tooth hanging down there. Well, we can have this little tool which actually kind of blurs it or pushes it up. So it's really handy because by doing that, we can actually see a nice clear outline of where our smile has been designed.
This is something that's impossible to do, in the traditional, workflow. I think, it would be much harder. I mean, here we can just literally just show them on the screen while they're sitting there. It's amazing.
So prior to this, for me, I was sitting with PowerPoint, and I was getting their images put onto the computer by the nurse, running into the next room, trying to mock it up on PowerPoint using some templates that I have, and then getting the patient in 5 minutes later. I'm trying to hurry up, change the little corners of the teeth and everything like that. And then you come to this, where I sit with the patient now and I literally walk them through what I'm doing. And it's excellent for communication, showing them that we're setting the teeth according to their face. And at the end of it, you can see a slider bar here. And essentially what we're doing is we're sliding back and forth and showing them what their current teeth look like. And then we're showing them what maybe a facially driven planning would look like, something like this. And this is very powerful. And this is excellent for case progression, I would say, to going to that next stage where they're happy to have a mock-up done or a try-in done of some sort of, you can do a direct mock-up of composite, or you can go to your lab and get them to use this to make a 3D, putty key for you, which you can try in.
I guess that's an important thing, because for me, my concern would be how can I guarantee the patient I'm going to deliver that just because it's on the screen? Exactly. And I guess we're not talking about cutting teeth or anything yet. We're still talking about a mock-up as a way of really checking the physical reality.
And I think it's really important to always frame it like that. This is not the be-all and end-all. You are not going to walk out with this 2D image in your mouth. This is to just give them an idea. This is, some rough planning, programming. It should be used for that purpose, and that needs to be clearly communicated to the patient to start with.
Okay. Shall we move on?
We should, yes.
Okay, I guess, look, I mean, in terms of summing it up, I mean, if I had to sum up what digital dentistry is and how it's affected my practice, and I'm not sure if you both agree, I would really say it's simplified my daily workflow. Like the amount of time, the amount of stress I've saved myself by having the scanner there, having the records there, having the ability to just really do more difficult cases or improve the logistics and the precision of my work has been, enormous. It's something that I don't think I could ever go without. And literally, it's increased my scope of practice. I'm able to do slightly more difficult cases. I'm able to, plan better. And when you can plan better, it's all about just execution, isn't it, Amy?
I can't agree more. The planning aspect of things and feeling more confident in what you're going to deliver is invaluable.
Okay. If you're watching us on Facebook, remember to like and share this post so your colleagues can catch up with what we're talking about. Anthony, most dentists who are watching us this evening will want to be very informed about how digital fits into restorative dentistry. So what can you tell us about that?
Yeah, look, I mean, 80%, I would say, as a general dentist, a lot of our work is restorative dentistry, and using an intraoral scanner, replacing the impressions, adding the tools in, it forms really a bulk of my workflow, and that's something that we're going to talk about now. I mean, this is my part where I'm going to go into a really focus and focus tonight's talk just on restorative dentistry and how that's applied for us, because as general practitioners, we all do some form of restorative dentistry, and how this applies to us is really, I guess, what I want to share and how it's helped what I do. And if I start off with comparing the traditional crown and bridge workflow, let's talk about indirect restoration, because we're talking about a workflow where we're preparing teeth, we're scanning, we're sending it to a laboratory, or we're manufacturing in-house ourselves. If I compare it to a traditional impression, I mean, each stage of the process, from pouring up the stone model, trimming the die, waxing, investing, casting, every stage has a tolerance for error. What I mean by tolerance for error is there is a small part that something can go wrong. And each time something can go wrong, it's going to magnify that. And basically, this workflow is what I would consider manual, But if I look at nowadays the way we do digital dentistry, or how we do our indirect restorations, we have a scanner. We know that's a certain level of, roughly a certain level of accuracy. which is very acceptable. It goes straight into a CAD design, which is a software where we design the restoration. A lot of people may not know that most of our indirect restorations have been manufactured digitally in the lab for many years. I mean, digital lab scanners have been around for over 20 years. I mean, it's something that every zirconia crown has some form of digital dentistry into it. I mean, even unless you're using the very old hand mill copy mills, most of these days, modern days, will have a lab scan and design on the CAD software. So then you only have a tolerance in terms, there is no tolerance in the CAD design. You have a small room of error in the milling, and you go straight to the fitting. So in my experience, this has really improved the accuracy of my work. And until you can see this yourself, you may not believe it. But Aodhan, how do you feel about that?
Yeah, I'd agree that if the reduction in the number of steps or the number of handlings, if you know what I mean, reduces those little errors, as you were saying, and those errors really add up at the end. So if we can reduce the number of overall steps as well, then that's going to reduce the error build-up and increase our clinical success.
I think errors are a big thing because historically the concern around some digital dentistry, or some people's concern, has been the level of accuracy, but apparently that's less of an issue than perhaps.
Yeah, look, I'm not an academic, but when I've trolled through some of the studies that are available now, and you'll see it in this slide, that most scanners, most bigger brand scanners, have been tested, and the research are coming out that they're relatively accurate, around 6 to 7 microns to about 45 microns. And this is all quoted in numerous studies. But I guess what I did find that in each of these studies, what I felt was more important is that each of them showed that all showed operator experience as a key factor in the results. And so it's actually about experience in there. Like, I might have experience in a certain scanner. You know, I'm definitely going to get a better result than if I pick up a scanner that I've never used before for the first time. So I think one of the key things we need to understand, this is a tool. You may not get the best result the very first time you pick up a scanner. But I can guarantee you, as you use it more, as you pick up more experience, you're going to be able to much better. You're going to be much more accurate in terms of getting that data. You're collecting data. It's like when we went to uni, do you think that now after, I've had 18 years of experience in dentistry, I can definitely take a PVS impression much better than when I was in dental school. And that's because I've had many years of experience. So I think we need to really compare apples to apples, and operator experience is a major factor.
Well, we often compare digital to analog as though analog is a gold standard, but is analog actually a gold standard?
Well, look, when I look at the evidence again, and I've seen a lot of other people who speak on this topic also mention some of these studies, is that there isn't many studies because it's so variable, because each lab, how can you test the fit of a restoration across in the general public? I mean, if I look back at these studies were done, back in the 80s, and they said that marginal gaps in fixed restorations of 120 microns are generally deemed as clinically acceptable. So if I have a scanner, which is even at the worst time around 50 microns, I'm still better off than compared to a traditional analog approach. Now, obviously, there are going to be people who can take a perfect analog impression and who's going to have a dental technician who can manufacture a crown perfectly. But in real life, in clinical practice, sometimes that we don't all have access to these people, especially people maybe in the rural regions who may not have access to those. And these type of tools are going to be, digital dentistry are going to help them so much more.
Well, Anthony, the title of this segment this episode is How to Get Started in Digital Dentistry. Can you talk us through your digital journey so far?
Yeah, look, I guess if I look at my digital journey, I've been very lucky. As soon as I graduated, I'm showing my age here now, but I went into dentistry, in private practice 2002, and I jumped in straight into a CEREC machine. So I used the CEREC for many years. Then I had a lot of experience in industrial milling with my friends, setting up a milling center. I was one of the, then I got experience with some of the first iTeros when they came through with Invisalign. And then slowly in about 2004, when I started using the now non-existent TrueDef, we went completely digital. We were doing implant restorations with the TrueDef and the 3D printers. And so overall, now I've progressed to using the 3Shape because it seemed to fit into my workflow very well. And we're sort of doing a lot of things with 3D printing. But, if I had to recommend people in choosing a digital system, I really think that we really have to ask the question, what type of work do you do in your practice? Because everyone is different. And there's no one system that fits everyone's practice. And I think it's important that they decide that system based on what they do. Do they manufacture themselves? Do they want to do it, or they still send to the lab? I mean, what amount of money do they want to spend to get into digital dentistry? Are they just using it for PVS replacement? There are a lot of low-cost scanners out there if you just want to use it as a PVS replacement without the apps. And basically, if you want to have a system where you want to have a lot of workflow, you want to have the apps that Aodhan's been talking about, there's a few systems to choose from, But, in my practice, if I look at what I do, I mean, this is generally what I do. This slide sort of paints the picture. I do a lot of restorative, like a direct composite. I would place implants, simple implants using guided surgery, and then I'll do indirect restoration. And I basically would do the guided surgery, and then I'll finish off with scanning that, and I'll use scan bodies to scan these and the crown prep and do this type of workflow. I still work very closely with my laboratory for many years. So for me, this type of workflow seems to work very, very well for me. But most importantly, if I look at the literature again, is that the literature has shown that patients often prefer intraoral scanning compared to the traditional impression. I mean, in your experience, have you ever had a patient that didn't like the scanning and wanted to go back to a 4-minute PVS impression?
Please, can I have the PVS impression?
Yeah.
Oh, no.
I get that question all the time.
I would agree.
But I guess moving on, I mean, if I had to share some experiences like pitfalls and learning curve, this is something that's really important. And I want to be really realistic about this. For my opinion, nothing is really plug and play. There is definitely a learning curve, and you need to invest the time, you need to invest the knowledge into that to get the best result out of your investment.
And you really need to have support, right? It's not about just buying a scanner, walking into your practice on Monday morning then, plugging it in and scanning everyone.
I can't buy a scanner from eBay and then just pick it up and use it?
You need to have training, you need to have that staff support from whoever's providing you this. I think that's so important.
I think it's very important to know that scanners really like white hard tissues, and that's across probably general board. Scanning soft tissues are obviously still the thing that we're trying to overcome, especially the lower mandible edentulous arches, flabby tissue. That from the pulsating of the blood flow has really sometimes makes scanning difficult. So we need to be aware of that. And basically we need to be case selective. So I would recommend starting with simple cases. When you scan, I've always been taught to use the premolars. When everything goes wrong, you always start from the premolars. If you ever always go back and pick up your scanner and premolars, it always stitch back. Look, I've had my fair share of things that go wrong, and this is a typical case where I tried to scan a lower implant bridge on edentulous distal extension saddle, where I thought I picked up the scan perfectly, and I came back and I got a implant bridge that didn't fit so well. But there's always a reason for things that go wrong. In this case, I realized that it was more to do with libraries, that we didn't actually correctly follow the workflow very well. But tonight, I really want to share with you a case just a recent case, and she's actually here tonight for us to sort of show her.
We'll meet her shortly.
Yeah, we'll meet her shortly. But this is a case that I want to talk to you about. Is Tanya, and it's a case where it's a balance between function and aesthetics. She came in with an aesthetic concern. So Tanya came in with concerns with the way she smiled. She wanted to improve her smile, and using what we call a facially driven approach, using a completely digital workflow and trying to be as minimally invasive as possible, I was able to create a relatively pleasant result for her. I mean, there are limitations. These are what we do day to day, but I think we got a good result here. And what I mean by facially driven approaches, now this is the modern term, but like we basically incorporating the use of the face or the smile, looking at the teeth not just in our little 5 by 5 centimeters. We really have to look at teeth as how it fits into the face. And this is a case where we had to go a little bit off the norm to achieve a pleasant smile. And basically, Tanya came to me and she was unhappy with her smile. She said, Dr. Mak, I don't like the gap between my teeth. I've got chipping, I've got a lot of chipping, and I don't like the color and the shape. I mean, what can you do about it? You know, and Aodhan, when she came in, I just did a general assessment, you know, and I looked at her, and then I looked at the way that her occlusion was. You can see automatically she was asking for veneers, but we had a much deeper problem than this. Just looking at that photo, you can see that she's definitely got some wear. She's got a very strong frenum. That thick frenum actually runs right across to the palatal surface of her teeth. You can see here on her occlusion, where it's extremely deep, she lost a little bit of posterior support. But my most concern when we talk about anterior restoration was how can we sort of not treat this kind of palatal wear? And so in this kind of cases, how I tackled this case was really good communication with the patient, like you talked about. But I asked my colleague, Dr. Con, who works with me, and I asked him, look, can we do some orthodontics first? I think this is one of those cases where, to be conservative, we really need to do some orthodontics. And Dr. Con did some orthodontics for me. And my goal or my brief to him was really close the space for me, level and line the arch, but most importantly, create enough space so that I don't have to prepare the teeth to restore these. And once this was her finish, and we've created the palatal space, and now we're down to the restorative part. How do I restore these teeth using my daily workflow? And for people who know what I do a lot, you know, I'm very passionate about my composite dentistry. I'm very passionate about managing these wear cases, and I talk a lot about what we call the alternate teeth, or the management of the wear cases using injectable resins. I mean, basically a technique where we don't have to prepare the teeth, and we can restore those teeth to an ideal, restore those tooth structure back for the patient. And in this case, where we did an alternate teeth technique, where in summary, we basically digitally mocked up every second tooth, and then we digitally mocked up the full tooth. And then we created a silicone stent so that we can inject into that to create the restoration. This is, for my opinion, I can only use this technique in a digital workflow, because I don't think it's impossible for a technician to hand wax something that's exactly the same, you know. And so if I move on and I show Tanya after this, you can see that I asked my technician, Brad from New Zealand, just mock up the teeth, but restore the teeth to what you think an ideal width to height proportion. And for him, he balanced, you can see he's increased the length of the laterals a little bit, and on the central, this is his digital mock-up. And this is what we call trying to use the ideal proportions to hit width and height. Now, we then 3D printed these models, and we brought the patient back. This mock-up was then done. And then we obviously would place the rubber dam, and then we would restore these using an alternate teeth technique. So we start off with using one side with our silicone stent, and we'll inject. I think this is a topic for another webinar, another Schein TV, actually, how to do this. And then we were able to do the full one using our silicone mock-up, and this is how she finished with the rubber dam still on. And you can see we restored using the injectable technique the 6 anterior teeth, and managing her wear, and I guess building up her palatal occlusion. And this was at the time of the rubber dam taken off. Now you can see where she started, and she had some orthodontics and frenectomy with a laser, and we finished her with some palatal injectable composites. She was relatively stoked already, until we started looking a little bit deeper, and you can see this was her afterwards. And it was very difficult to match the composite using a single shade. If I go an opaque shade, it will be too opaque. Here it was we knew at the beginning, we talked to her that we would probably need to cover something at the front, and she wanted whiter teeth. And so obviously I discussed the options with her, but whether to do this in composite or ceramics. But mainly the one thing that really you can see from this photo where we had to change our treatment plan a little bit differently was that what we've mocked up as the ideal height to width ratio, you can see in her smile, she actually didn't show much teeth. She wanted a better smile. She said to me, I would like to smile better. I want whiter teeth. And she actually didn't show much top teeth afterwards. And so I said, look, this is where something's not right here. So when we go to the next step, where we now think about how to restore the labial surfaces of the teeth, we really look at what I call the facially driven approach. And what you talked about, I said, why don't we put her through the smile design? You know, and I use the 3-shape smile design because this is the app that I have in my practice. And I said, let's have a look at what it looks like if we can modify her smile a little bit. And I worked together with my technician, Brad, and he mocked up this teeth. And if you look at it closely, you can see that we needed to actually increase the length of her tooth. And I said, Brad, her teeth are pretty long already. If I increase the length even more, I'm a bit worried that it's going to look too long. And I said, look, from this smile design, if I look at it from a facial driven approach, it's telling me that she needs more length. She has a deficient maxilla, you know. And so we mocked her up, and you can see she looks so much better.
It is a good lift.
Yeah, and this is what we call about facially driven. And if I had to make a recommendation, we now do these anterior cases where it has to be facially driven. Rather than tradition, we just used to be restoratively driven. You know, we've taken aesthetic dentistry to another level. We can no longer just mock up a model and ask the technician to just look at the stone model and mock it up and expect that this is going to give her a beautiful result.
Well, I suppose we're really enhancing our predictability, aren't we?
Exactly.
And we're really doing the right thing by the patient by doing that extra planning.
Can you imagine if we did these veneers for her and we didn't use a smile design? She's going to end up still having short teeth and not really having the full potential for her smile. So to add to another level what digital dentistry can do, Peter, what we did was we actually designed a trial smile. So we got the mock-up and we basically 3D printed some shell temporaries. Okay, this is a copy of her mock-up. We created some shell temporaries. And I said, because I'm not sure if this is going to be suitable for Tanya, I want to try this in her mouth. And traditionally, we would probably take a silicone stent, we'll inject some temporary material and try it in. But now I can prepare all this in advance. I've prepared all these shell temporaries so that when she comes in, all we need to do is just pop them in to trial smile them. And you can see in this slide, this is her after ready to try in these temporary veneers. And we just basically 3D printed them. And for those who are not into 3D printing, it's really amazing. There's really no adjustments required. I mean, we very rarely have to adjust. And you can see that she's got very bulbous teeth. So we had to sort of roll these shell temporaries in there. And how I tried it in was I basically spot etched them. I would basically just put a couple of spot etches, and then I would basically then bond these in so that they can still come off. Funny enough is that I probably didn't bond them in well enough because we had to put her in an orthodontic retainer, and the orthodontic retainer would probably pull a couple of these off a little bit shorter than I wanted to.
Anthony, we've had a question. What material did you use for the shell temps?
This is a material we 3D printed called GC Temprint. It's a material that I've had some good experience for a while now, and I know that they're releasing it in I guess early new year. And I love this material. It comes in different shades, and it's such a predictable material. And if you look at her now with the trial smile, this is her smile now. I mean, this is so much better than what she had before. And you can see she's got some nice smile which follows her lower lip line, and it's a much pleasant smile. And from here, we gave the option of whether to do composite or ceramics. And Tanya was really, said, look, I want a really long-term outcome. I want the best outcome I had. And she said, whatever you're confident with. And I said, if we wanted a really nice white smile, a really long-lasting, low-maintenance sort of restoration, let's go with ceramic. Now, I really wanted to do this no preparation. But because of the way the teeth were really bulbous, I couldn't do that. We spoke with Brad. Brad says, we're not going to be able to do no prep because you're not going to get a good path of insertion. So we went with what we call guided preparation, or minimal preparation, basically, where we just prepare a margin and just remove a little area where it's most bulbous. And you can see this is actually the preparation. I mean, we tried to keep the margins super gingival so that they'll be able to bond very, very easily. And look, you know, for me, I wanted to see how, everyone will probably ask, how much did you prepare, right? How would you consider this minimal preparation? And I was interested as well, because we used the guided preparation where the temporaries are in there and we're cutting back. And
so you cut through the temporaries as though they're natural tooth structure to give you
the minimum thickness I need for a lithium disilicate restoration. So anywhere between 0.5 to 0.8 thickness. We knew we wanted to be additive, so we wanted to be additive. So we don't mind that we had a little bit more bulk in the ceramics, but we just couldn't do it no preparation. So I basically put her into a soft. I scanned her, and I had to scan the prep and a scan of the original preparation. And I put those two scans together in this software that I have access to, and it basically measures the differences between the two scans. And you can see here, using the table on the right-hand side, where green means that there's no change. It means I didn't prep that area at all. Light blue is basically 0.1 of a millimeter, so it's 100 microns. So in the darkest areas where there was most bulbous, the maximum prepared for her was 0.4 millimeters. So I had assurance that I was still completely in enamel. So these restorations were completely enamel. And then I would then ask my technician, Brad, from New Zealand, to finish the mock-up. And you can see that's the mock-up. And we went and he manufactured these veneers by basically milling them in wax and then pressing them in the lithium disilicate. So then Tanya came back and we bonded these veneers in on the rubber dam. And we were able to get a nice isolation and finish off with some nice veneers. And when I first looked, I myself thought they looked a little bit long. You know, I said, look, these are, have I done the right thing, Aodhan? Have I done the right thing in making these teeth? But then I look at her and I got her back and she smiled at me, and then you can tell.
It's beautiful. Facially, it's wonderful.
It's bang on. And I couldn't have done this if I didn't have this Smile Design app, because I would have got it wrong. I would have made the teeth using the height and width proportion, and that wouldn't have sit very well from her. And from here, where we started off, this is where we started off with her. There was a drive for aesthetics. She wanted to improve her smile. And you can see now how she's got such a pleasant smile now.
Beautiful, hey?
Well done.
And she's here with us tonight. And she's here to share her story, and she's here to allow me to scan her.
What's the plan with that scan?
Look, she's just finished. This is like we haven't planned this. We just said, look, this case is suitable for us to discuss, because I think it's something new that I can show. And we finished the veneers, and now we're really just making her a long-term retainer. She still has an implant that we need to do in the posterior segment, but I would like to give her a splint, a temporary splint, so that we can basically protect those veneers for her. So I'm going to scan her with the new Trios 4 from 3Shape. It's a scanner that I'm very excited about personally. And we're going to scan her and get that and send that off to Brad to make her a splint, either 3D print the splint or mill it. And we can then move on from there. But I'm going to leave you boys here to answer some questions while I pop down and I'll introduce Tanya to everyone.
We'll see you shortly. So, getting to some of our questions, one of them is, what are some of the challenges you faced when switching to digital dentistry?
I suppose there's always that question in the back of your mind: is my scan going to be accurate, or is it really going to fit the restoration? And I know that there's, for my first few restorations, I took some PVS impressions as well.
As a backup? As
a backup, and just for peace of mind. For me, I'm pretty cautious. I don't jump into things. If that restoration is not adequate, then I've got something which we can go ahead and make, an adequate fitting restoration.
So did you use that PVS impression to send to your lab technician so that they could compare it, or did you just keep that in your top drawer so that when the lab designed crown came back, you could try it on the model.
I did both. Yeah. So I think that it's always nice to work really closely in conjunction with your lab. And if you're moving into a certain realm of technology, they need to be ready as well. If they're not ready, then it's, you know, the relationship is not going to work. So you both have to be on the same page with these things.
Okay. Well, going to what you were talking about training earlier before, how long did it take you to get used to the Smile Design software, and did you have to go on a training course?
It wasn't that difficult to get used to. It's pretty basic. They've set it up really, you know, Smile Design for Dummies sort of thing. And I think it's excellent because it's really efficient to use in front of patients. You're not messing around. You're not questioning, oh, God, have I done this right? Or am I going to look like a bit of an idiot in front of patients? You know? So I think that it's really straightforward. There's lots of videos on YouTube by 3Shape on using their Smile Design software. And they're very recipe, you know, textbook, you know, do this, do this, do this. And there's example cases you can use. So they can give you example cases, and the support's excellent. So for me, for my first few, I wanted someone to give me a hand, to hold my hand while I'm doing these, and there's always someone there for you to give you a hand.
Okay, I think we're ready in the treatment room, is that correct?
Yep, we are ready. Excellent. So I want to introduce our lovely patient here, Tanya, to the audience. We're going to scan Tanya, and one of the things that I want to share with you, for me, when I do the scanning, I always use this little tool. It's called an Optrogate. Basically, it's an Ivoclar product, and it basically keeps the lips away. I think moisture control is still very important if you want to have a very accurate scan. I know the scanners will be able to scan with some form of moisture, but in my personal experience, I find that I get a better scan when I can keep it dry. So it's very simple just to place this Optrogate in here. I'm just going to stretch your lips a little bit, Tanya. Now, Tanya's, I would say, is not the easiest of scan. I guess the longer the teeth, the harder the scan, and if there's a little bit of interproximal sort of space or a little bit of, for example, like perio patients, they're always a little bit harder to scan. So if you can zoom in here, you can see Tanya's new veneers. You know, pop your chin down a little bit, Tanya. So they look really nice, and they've settled in. The gingiva looks really nice. So we're going to scan her top arch, and then we're going to scan the bottom arch, and then we're going to do the bite as well. I'm going to use the latest Trios 4. This is, I mean, I've generally have a Trios 3 in my practice, and to be able to use a wireless scanner now is going to be a godsend. I don't have wires sticking over the heads, right, Tanya? Being wireless is great. This is shown to have great battery life, and the way they've done the tip is so that it's quite resilient. So, you know, I'm really excited about having this in my practice, in my hands. I always start from the premolar. I'm going to show you here, this is the 3Shape sort of workflow. Tanya, I'll get you to open wide for me. And I can tell you Tanya really didn't really like the impression, so she really enjoyed us having the scanner. So I'm always going to start from the premolar, and this is how we scan. I'm going to do it nice and slowly because she has a lot of interproximal spaces as well. So this is working. It doesn't have my machine gun sound. So I usually would have a sound which would really help me because I wouldn't need to look at any sort of monitor. But I basically roll around the premolars from the occlusal, then I'll go palatal, and then I'll roll, and then I'll finish at the buccal. This is how I would scan there, making sure I've captured everything. Even up in the upper 7, you can see that I've had no problems scanning the upper 7 and even into the interproximal cavity. So by doing this technique, you know, I'm going to jinx myself, but you will definitely see how I actually don't stop. And the best way to scan across the arch is to roll. Well, you can see I jinxed myself there. And if you roll across the incisal edge, you can see you get a very stable scan. Okay? Now I'm coming across to the other side. And even on the distal of the 7, you can see I've been able to reach that area. Okay. And then on the distal where there's an edentulous space, I'm able to now come across and trying to get any sort of spaces there.
Anthony, we've had questions about how long it takes you to do an intraoral scan versus a PVS impression. Obviously, in Tanya's case, there are a couple of challenges, so you might be going a smidge more slowly. But on, if there's any such thing as an average patient, how long would it normally take you?
Look, on average, I can generally do a scan in about a minute, okay? So here we're in a minute.
And that's upper and lower?
No, just the upper, like just one arch. So probably about a minute or minute and a half for each arch. So here, if I get Richard to just show them, I've got pretty much everything. I think I may have missed just a little bit of the mesial of the 7, but I've got a full arch 7 to 7. And I've really, one spot there you can see, which I can go back and scan just on the mesial of that 1/7. This is if you get a drag, you can't get to it, but here with the scanner, I can get to it. And now I've finished the top scan, and that's pretty easy. And I guess the new tool with the wireless is I can actually move scans, and I can now scan the bottom. If I go back, all right, now I'm ready to do the bottom one. The bottom one is generally a little bit trickier. So open nice and wide. You'll need to retract a little bit, and this is an area where it's quite tough because there's a bit of undercuts, but it's still definitely scannable. See, again, I start from the premolar. You can see how I've rolled. Open nice and wide for me. That's it. And I've rolled, and all the way even up to the 8. I've come in here on the lingual of that tip 7. And I'm almost going to get all to the 8. You can see I've got most of the 8 there. And here, if you get stuck, I go back to the premolar. See, you can't sort of go wrong with going back to the premolar. In the distal. And where you've got undercuts, it's not just difficult for impressions, but difficult for scanning as well. Okay.
Anthony, would you have any tips for getting those undercut areas? Say, you know, the distal of that 5 there. I sometimes find it a little bit difficult.
So you generally ask the patient to open nice and wide, and you basically roll like this. We generally just ask them to roll, and we generally go over it, and eventually we'll get most of it. But one of the things is that if you get a little bit of a spot there, a little window, what you will find that is that the software will be able to basically close those holes. Okay, the software will be able to recognize minor little holes. You can see now I'm just rolling over the lingual, and I'm going to ask Emma just to suction on that lingual as I come across the other side. Perfect, yep. And then I think I'm okay. Now I'm on to the other side now. Okay. You can see how I'm able to close a little bit, Tanya. I find that if I ask them to close a little bit, it actually helps as you come around the lower anterior. Close a little bit more. And you can see how I just make one pass straight across.
Anthony, another question, are there any pre-procedural mouth rinses you prescribe before scanning?
No, definitely not. I don't think there is a reason for it. We're just capturing data. Obviously, you want the patient to have good oral hygiene. But yeah, we've got a pretty good scan there. Richard, I'm going to show them the bite, I guess. We can show them the bite. I think we've got a good splint. I'm making an upper splint.
Oh, you want to go
to the bite. So one of the key tips about scanning the bite is that you need to trust more than the software. You want to be able to scan a few more teeth. The more data you give people, the software, the better they're going to be able to scan the bite. So I'm going to get you to bite together for me, Tanya. So I'm going to start from the back. You always have to start from the back. Okay. And you can see how it's picked it up straight away, but don't stop. Keep scanning. I always keep scanning right past the canine, almost to the other side, the lateral, because you're going to get much better data doing it this way. Okay. And you can scan the other side. Richard, can you press bite 2 for me? Bite together for me, Tanya. That's it. Good. You always start from the back and you run it across and don't stop. Even though it's stitched, I keep going and I scan all the way to the other side. And that's going to give me much better data in terms of getting the occlusion, because with digital dentistry, one of the things that people sometimes commonly tell me is that they have struggles with scanning the bite. And I think if you can give the scanner more data, it's going to give you a much better eccentric occlusion. But what really has changed the way we go now is to actually do a dynamic motion. So we can actually see how Tanya functions in motion. So I'm going to ask Tanya to bite together. And then when I'm going to tell you, I'm going to ask you to slide to your right. Yep, a little bit, yep. And then come back to the middle. And then slide to the left. Come back to the middle. Slide forwards. Forwards a little bit more. Yep, bring your jaw forward. That's it. And then just go tap, tap, tap a little bit. Yeah, okay. So we're going to try and show the range of movements. So basically, if I do it this side, bite together, I can do either side. Okay, I'm going to show you how to do it. So Tanya, I'll get you to now slowly slide to the left. Yeah. And then slide back to the middle. Grind to the right. Yep, the other side. Yep. Bite back into the middle. And then slide forwards. Perfect. Yep. Okay. And then back to the middle. And then just gently tap, tap, tap. Gently, gently. Yep. And then grind your teeth. Just side to side, side to side. Yep. Great. And you can see here on the screen, after it processes, we can actually see how her dynamic movement is. This is, for me, much better information than the traditional, what we call virtual articulator or the articulator. It just makes things, it allows the dental technician to give much more information. And if you can give them more information, they're going to be getting a much better result, I guess, from your laboratory work.
Anthony, we've had a question from the website. Does it matter the sequence in which Tanya does those movements?
For me, no. I mean, I think I just find it's easier to start with lateral movements first and then go. You can literally get the patient to just grind naturally, how she chews if you want. But one of the tips is to ask them to do it relatively slowly and not to open too wide. Like you can't get them to open too wide when you're doing it. Yeah. I think we've finished the scanning. It's processing now. But I guess, are there any questions for Tanya or anyone, Peter?
Well, a question that I would have, Tanya's obviously had some impressions taken in her life before. Tanya, how do you find, in your experience, analogue impressions, so impression materials, compare with the digital scan experience?
It's a lot more comfortable doing it this way than the impression way, purely because I find the impression way, I want to choke a lot, and you have to sort of leave that impression there for quite a length of time. This is a lot simpler.
Great. Would you ever go back to the old way?
No, not with this technology. I think this technology is also more defined as well in terms of what it's showing the dentists as well.
I think you really enjoy being able to see the final vision of it before it is. It's more reality. You can actually understand. You I guess you're knowing the process, which stage of the treatment. I think.
Definitely.
Yeah. And I think
Well, Anthony, we've had some questions, and Tanya can chime in here as well if you'd like, Tanya. Do you feel that the future of dentistry is really going to involve having scans every 6 months, for example, in order to enable things like patient monitoring?
I don't know if Tanya knows what patient monitoring is, but basically, Tanya, patient monitoring is an application where we can see how much wear that you're having over time. As you know, you came in, there was a bit of wear at the back, and we had to sort of fix that first. Yeah. So imagine if we can scan you every 6 months, we can actually monitor it and actually tell you earlier, Tanya, this is getting worse. We can see it. We can visually see that it's getting worse now. Maybe now's the time for treatment. So, we may not have needed to wait so long before we started doing it. We would have maybe saved more tooth for you. I think that's the main thing, is to keep more tooth, isn't it?
Yeah, definitely.
So, Anthony, I guess my question should have been divided into two spots. So the first question would be for you, Anthony. Do you see that this sort of thing could form part of a 6-monthly or a periodic recall regime?
Yeah, definitely. I would really want to implement this with my hygiene team. and basically they'll be scanning the patient every 6 months when they come for the recall patient, because then you can always have the most up-to-date scan. It's almost like a medical record, like your x-rays where you take every couple of years. You've got the scan, so if something happens, let's for example, you've got some broken teeth or a crown is completely snapped off and you need to make a temporary for her. If you don't have, the patient will come in and say, oh, I've lost the tooth. You know, you can always go to that scan, you imprint the model, and you can actually rebuild and make her a temporary straight away. So yes, to answer that question, I definitely would be scanning in the future every 6 months.
So the second part of the question is then for Tanya. Tanya, would that be something you'd be willing to have done at your periodic dental checkups?
Definitely for me, because originally that's what the whole problem was, is that I had worn my teeth. So like Dr Mak just said, had I known earlier, I probably would have saved me a lot of the work that I had to get done. But in saying that, you know, I definitely, you know, recommend this technology for that reason alone.
Okay.
Just for wear and tear.
Anthony, we better bring you back to the desk, but Tanya, thank you very much for being with us, and congratulations to you and to Anthony on a beautiful result. Well done.
Thank you.
So, Aodhan, is this sort of scanning technology suitable for subgingival margins?
Yes, it is. So, you know, I think that the same principle should be applied regardless of what type of impressions or scanning we're taking. We need to have good tissue management. We need to use some form of retraction, whether it be retraction cords or paste, whatever your preferred method is. We need to essentially get the tissue away from the margin so that we can get a clear scan.
You've obviously had a lot of experience with soft tissue lasers. I mean, you've been on an episode of Schein TV on lasers. Do you find that lasers and scanning go hand in hand?
Yeah, well, there's situations where you've got deep margins that are, and hemostasis may be an issue, and that's when your lasers will come in hand in hand with then being able to take an efficient scan.
Anthony, is there still a place for retraction cord in your hands?
Yeah, I use retraction cord ever more so now with my crown preparation. I just find it, for me, it's easy. I went through a phase where I did a lot of lasering, and I was a bit concerned with when we laser that we may sometimes get some recession of the tissue. Sometimes where we've lasered maybe a bit too much, and then when the crown comes back, the margins becomes too supragingival. So I'm using now a lot more retraction cord, but I'm just using a simple one cord. I think why I use this is now because I don't have to worry whether I've captured the sulcus or not in it compared to an impression, because I just literally as long as I can see the gum and the tooth, I separate it, I can scan that. But in saying that, I mean, I still would use a laser in those very deep areas. You know, in those very deep cases, I would definitely still use a laser.
Okay. Are there annual fees for trios?
They're called license fees, and if you use a certain app, then you pay for that one. So you only pay for what you use. But I think one of the things that we really have to bring up here, and why I like this sort of thing, is that you have security. When you're paying a license fee, there's a responsibility for the companies to make sure that they keep your data private. You know, they have, this is based in Europe. There's a lot of privacy laws in Europe because of where the company is based in. And so I have the assurance that the cloud base or the upload base is secure. And I know that my data and the protection of my patient the data of my patient is protected. And for me, that's a very strong thing moving forward, because if you want to just email or scan, it's possible, but how do I know if my emails are not going to get hacked, or how do I know if my lab is storing those files properly?
Data security is going to be a big thing for all of us. I mean, it already is. Aodhan, is the Smile Design software included in the 3Shape software, or is it optional?
I think it's an optional application, as Anthony was saying before, where we can add it on. Is that right, Anthony?
I think it depends which ones you take on. I think if you go with the very basic version where there's no apps involved, but if you're buying a Trios 4 with the basic ones, like I think the motion scan is included. I think I think that the Smile Design is included, depending on the level of what you buy into. Yeah.
Okay, good to know. A question for both of you: how does this scanning technology integrate with CBCT? We've had a few questions on that front.
Yeah, look. For me, the way I would use the scan with the CBT at the moment is really for implant planning. Okay, that's the only time that I'll marry the two scans up. And for me, I'm using the Implant Studio software, which comes with the 3Shape in the 3Shape workflow, and I can import any DICOM file into it. So if you're taking a CBCT scan, nearly I think all CBCs should be able to export a file called DICOM data, and that data is actually readable into my implant planning software. And it's actually quite easy to do. So my assistants will export the CBCT into a DICOM set, and I literally click and drag it into Implant Studio, and it literally marries the two scans up. I don't know, is that how, what about you?
The exact same, very, very similar.
Yeah.
Good times. Okay, is scanning easy to do if the teeth are crowded?
I think for me, the crowding is not an issue. Obviously, if the jaw is small, then yes, that is going to be an issue. But then I think taking impression will also be an issue. So I think with practice, I find that I don't think I've had as much trouble as when I first start. I think it comes again down to an experience sort of level. I think the more experience you have, the more you understand what can be scanned, what you can't. I'm at the point where look, I've had a few years experience now, and I'm down to, like I said, over 90%, 95% of cases I would scan.
Okay. Aodhan, do you ever use scanning for mouthguard construction?
Yeah, frequently. Yeah, so that's my go-to for mouthguard construction. I always, and same for splints, I'll go digital scans for splints as well. Yeah, the key is to work with a good lab and both be on the same page and have an understanding, have your parameters set, and we've had great success with that.
Okay. Well, on the lab front, how much did you find that your lab turnaround time changed when you switched to digital dentistry? If we start with you,
Oh, look, it's a massive change for me, because the labs that I traditionally used, Brad is based in Auckland, so we always had to send everything by DHL, you know. But now, like, we could get things done overnight. Like, with click of a button, and Brad's received it. I can communicate with the cases with him. Most importantly is, like, how many times have we tried to, we've done a case and we want to speak to our technician about it, but really they're just thinking we're just gibbering because they don't actually have the case in front of them. So here, where you've sent the case, within 5 minutes, he can bring up that scan. He can actually see what you're trying to explain to him.
Talk in real time.
Because for me, as I'm getting older, I'm more of a goldfish, man. I forget things, you know. I've got short-term memory. And so
it's okay, Tana's out of the room now. She didn't hear you say
if I don't if I go and speak to my technician there and then, like if something's not right, if I don't speak to them there, I'll probably forget it. So I actually really love this, that we can send the data through. I can pick up the phone, and, you know, Brad's saying you're getting pickier and pickier at me, because I guess it's made easier to do it. You know, get easier to communicate with them, I guess. So yes, in my workflow, yes, we've saved so much time in terms of communication, and then the return lab job, because they can start on it straight away.
Aodhan, your lab is substantially closer to where you work. Has it still made a difference for you?
Yeah, my technicians will try and push it out as much as possible to just take their time, but I agree. You know, I've got an in-house laboratory. And obviously we're not sending things overseas to New Zealand for Brad and things like that. But it's the same concept, that the technicians are not having that time where they're pouring up the models and all the nitty gritty little bits and pieces. Is simplifying that process for them. So there is an increase in turnaround time.
Okay, as in a decrease in turnaround time.
Sorry, a decrease in turnaround time.
That's good to know. Okay. Final question, because we're running out of time. Where do you both see digital dentistry going in the future? If we start with you, Anthony.
Oh, look, we're at the cuspal tip of it. You know, there's so much more we can do. I'm really looking forward to some of the workflows that some are early available now, where you can incorporate the CBCT and this face scan at the same time. So it saves a lot of time, rather than what Aodhan showed, inputting the photo and trying to verify the position of the jaw to the photo. With that future, that's just going to open up so much more opportunities for me, because we can rely that that's the face and the jaw and the CBCT are all married up automatically. And then hopefully with 4D jaw scanning as well, with the CBCT movements in there, we're able to see so much more. Just having vision. If we can have the data, we can have the information, we can plan better. If we can plan better, we can, I guess, achieve better results for our patients. So it's going to just get better and better. Yeah.
Aodhan, what are you excited about?
I would say the exact same sort of thing. You know, it's all about the facially driven aesthetic outcome for our patients, and you know, we'll see with time, as you'll have seen, you know, over time as well, that applications are coming here and there, and they're becoming more common now in these past couple of years. So I'm excited to see what's next as well.
I think it's to dive in. I mean, look, it's one thing I can share is that digital dentistry, there is a learning curve. You know, it's not something that you can expect to know straight away. Like, I've got a scanner, I'm now, you know, a digital dentist. There is some time that you need to learn the system using, what the capabilities are. But most importantly is understand when things don't go right, where they went wrong. Because a lot of times if you have too much things happening, you may actually not know where it actually went wrong. But I think now is a really good time to dive in, I would say.
Okay, well, we are out of time. So, gentlemen, thank you. You've given us an inspirational peek into your digital world. So thanks again for joining Schein TV.
Oh, thanks for having us.
And thanks for having me too.
And thank you for watching. To claim your CPD certificate, head to henryschein.com.au/TV and click the link. If you have any questions about what we've discussed in this episode, check in with your Henry Schein rep. Thanks again, and see you soon.